got about 20 seconds or so.
So we'll give a few minutes to allow everyone to start coming in here. I know everyone's asking, where am I today? I know it looks like I'm at the Regal Royal Room. I'm at my mom's place, and no, she's not the Queen of England, but we certainly treat her like that. So we'll let everyone join us in as Maria lets people in. I just want to welcome everyone, though, today to the last OC3PR of 2021. Yes, it's hard to believe yet another year has come to an end, and we are still dealing with COVID. As such, today's webinar is a fitting episode to conclude both the year as well as the series of OC3PR that have been dedicated on COVID and its significant impact on the delivery of critical care. As most of you know, OC3PR is the educational series sponsored by Critical Care Services Ontario. Its mandate being to help provide the skills and knowledge to health professionals, be they medical care providers or administrators, essentially anyone that ensures care is provided to critical ill patients at the highest possible standard. All of the previous OC3PRs are available from either the CCSO website or also from their YouTube channel, which we encourage you to check out. For today's session, you can ask questions by submitting them to people name Q&A, stands for question and answer, via the Zoom chat feature. Today's questions will be fielded by Drs. Josée Thériault and Michael Sullivan, who are both members of the OC3PR committee. As always, please do your best to keep yourself muted for today's presentation. When COVID began, it was evident that this infectious disease would have huge ramifications on critical care. Our OC3PRs to date have understandably focused on issues relating to caring for COVID patients, be it treatment, vaccines, staffing, or patient transport of these very sick individuals. In the new year, our OC3PR will begin to address other critical care issues, but of a non-COVID nature. Yes, it's hard to believe that there are other issues that aren't COVID related, but rest assured, we will continue to address COVID concerns, as clearly this disease is not going away. Perhaps the one COVID issue we've been somewhat remiss at not addressing sooner is to discuss what has been the lasting impact this disease has on patients, their families, and friends. Given that we have been dealing with this virus and its variants for almost 2 years now, there is a growing appreciation of the long-lasting and often devastating impact this illness has on patients and their families. As we will hear today, there are very concerning concerns that need addressing. To help us better appreciate these challenges, we are very fortunate with us to have today 2 individuals who have been focused on helping COVID survivors and their families. The first is Dr. Margaret Herridge, who is a professor of medicine and senior scientist at the Toronto General Hospital Research Institute. She's received numerous awards and recognitions and is an international expert, as she has published extensively on patient and caregiver outcomes after critical illness. She is director of the Recover program, and of interest for today, she is the co-lead on CANCOV, which is a Canadian multi-center study that is looking at the 1-year follow-up of patients and caregivers after COVID. Her co-lead is our other guest today, Dr. Angela Cheung. Dr. Cheung is also a professor of medicine and is the KY and Betty Ho Chair in Integrative Medicine at the University of Toronto. And she is a senior scientist at University Health Network. She has had a very accomplished academic career with numerous awards and publications. She is presently a Tier 1 Canada Research Chair. She had attained her medical degree from Johns Hopkins University in 1988 and then a PhD from Harvard University in 1997. In addition to this, importantly, she brings the experience and knowledge that she has garnered from caring for patients and their families for over 30 years. Dr. Herridge, Dr. Cheung, thank you both for taking the time to speak with us today about the long-term health sequelae in COVID patients who survived a hospital discharge, including issues about rehabilitation, as well as to better appreciate what needs to be addressed to better meet the needs of COVID survivors and their family. Ladies, thank you again. I believe, Margaret, you're going to begin, and I'll pass it on to you. Thank you both.
Thanks very much for the kind introductions. My co-lead on CANCOV, Dr. Angela Cheung, is going to start off the presentation today.
Yeah. And we just want to thank OC3PR for inviting us to this webinar. And so what we thought we would do is to share with you what we have learned in CANCOV. And this is a very large-scale study across Canada. Next slide, please. Next slide. As Dave mentioned, it is a prospective cohort study, and we have many investigators, more than 100 investigators. These are some of the principal investigators of the study. And we originally planned to recruit 1,000 patients who are hospitalized and 1,000 patients that are not hospitalized. And also their caregivers across different provinces in Canada. And so we have centers, we have 18 centers across British Columbia, Manitoba, and Alberta, Ontario, as well as Quebec. Next slide. And what we really was trying to do was establish a platform where we can decrease the patient burden and collect patient-centric sort of data, both clinical data, research data, as well as biospecimen. And with the biospecimen, we're talking about looking at genetics, epigenomics, transcriptomics, metabolomics, and other biomarkers so that we can better understand COVID-19. Next slide. The overall objectives are to determine the short and long-term outcome of patients with COVID-19 and their caregivers in Canada, and also to examine the social demographic, clinical, and multi-omic determinants of these outcomes. Next slide. So what we did was we recruited patients at baseline, 7 days, a month, 3 months, 6 months, and 12 months. And we actually have been extending the follow-up to 18 and 24 months as well. And at each of the visit, we collected data on comorbid illness, medications, and what they're doing in their daily activities, their work status, symptoms, their quality of life, mental health, resilience and stigma, as well as complications from COVID-19. And we do a physical examination and test their function, looking at 6-minute walk test. And we also look at their nutritional status, healthcare utilization, and also how they're reintegrating to normal living. Next slide. So this platform is really, we wanted to facilitate other people asking questions. And so we established this platform in connection with Recover, which is an ICU study led by Dr. Herridge to look at long-term outcomes of people who survived ICU. We are working in conjunction with Gemini, which is the General Internal Medicine inpatient initiative looking across Ontario. We also look at hospital discharge and the transition between the hospital and going home or to rehab facilities or to other care centers with pods. And we are also connected to other studies like COVID-free at home, that's monitoring at home for COVID-19 to know when to send someone to the hospital. As well, we have imaging studies like the cardiac imaging study and the neuroimaging study, as well as biomarkers, which are in purple. So cyclic study is looking at complements and also the endothelial function. Beacons is looking at coagulation issues, and CANCOV is looking at antibody and viral sequencing type data. And ICU MEND is another study that looks at muscle function. So there are many different studies. I won't go over every single one of them, but I just want to let you know that we set up a platform so that we decrease the burden for patients, where we can maximize the data and our understanding of COVID-19. Next slide. So to give you an update, right now we're around 1,800 participants, with about 672 who are non-hospitalized in the non-hospitalized cohort. And we have about 300 patients in the non-ICU cohort and about 300 patients in the ICU cohort, and a number of caregivers as well. Because of patient advocacy and because we did not have testing early on in the pandemic, we asked patients to stay home, isolate rather than going to a testing center. There is a group that was never tested for PCR tests, nasal swab PCR test. And by the time that they were able to test, it's already quite far out from their acute illness. And so because of patients saying that, we think we had COVID and can we enter? So we established a cohort like that with 439 patients in it right now. Next slide. So what I'm going to do is to give you a look at our data. This is very preliminary look, and it's not really for sharing widely. There's ongoing work trying to clean the data, trying to fix the missing data and other things. Next slide. But I do want to give you a feel for sort of who have been recruited to CANCOV. So you can see they're divided into the first 3 cohorts, which was what we wanted to do. And then there's a 4th cohort, that's what I call the screening arm. You can see that the older people are hospitalized. So the average age of the non-hospitalized group is 48. Our starting age is age 16. So that's the inclusion criteria, anyone over the age of 16, and we certainly have a 16-year-old. And we don't have any higher limit per se. And so our oldest is 96 years from the hospitalized cohort. And you can see that in the ICU group, the average age is 54. You can also take a look at the sex of the patients. There are more non-hospitalized patients who are female, and there are more sort of men in the hospitalized group, especially in the ICU group as well. And same with ethnicity. You can see that the non-hospitalized group, 70-something% Caucasian, whereas there are more racialized groups, East Asians, South Asians, and other ethnicities in the hospitalized non-ICU and ICU arm as well. Next slide. So I want to tell you a little bit of an anecdotal story, and mainly about the screening arm. There's a family. The index case is on the left, and so that's a student at U of T, and he had a viral illness in March, brought it home to his brother, so on the right, and his mother and his girlfriend, and they all had a viral illness. And so all 4 of them were in our screening cohort. The index patient plus his mother and his girlfriend tested positive for serology. So tested positive for spike protein. This is before vaccination. And you can see he actually had comatose many months later, and his brother also had comatose. And what happened was I treated him and his brother for his comatose, and he recovered quite well. But his brother, who's antibody negative, has worse symptoms, actually had seizures post-COVID as well. So this clinically diagnosed cohort is an important group to think about. Next slide, please. And so the WHO has a case definition for post-COVID condition that I want to share with you all. So this was just recently established in October. And so they included a probable or confirmed SARS-CoV-2 infection. So you don't have to have a confirmed test. A probable is under this umbrella. And they define it as usually 3 months from the onset of COVID symptoms and lasts for at least 2 months and can't be explained by alternative diagnosis. So the common symptoms include fatigue, shortness of breath, cognitive dysfunction, but there are many symptoms. Next slide. So tachycardia, insomnia, and you can see from this slide that really almost every single system can be affected. That has to do with the SARS-CoV-2 virus, and it enters the cell through the ACE2 inhibitor, ACE2 receptor, and that receptor is quite ubiquitous across our body. Next slide. So in Canada, we have about 1.8 million cases, and in Ontario, about greater than 600,000 cases. And if we think about using a very conservative estimate of 10% of these cases have post-COVID condition, that means that in Ontario, we have greater than 60,000 people with post-COVID condition. Now, that estimate may be higher because based on literature review, it can be as high as about 50% based on a PHAC review that was done, Public Health Agency of Canada. And so it's really important to, think about sort of the sequelae of COVID-19, the long-term issues. And with that, I'm going to pass it over to Dr. Herridge to talk about the ICU cohort.
Thanks, Angela. And I'm going to talk now a little brief background on ICU outcomes and just begin this discussion with the following thought, that COVID-19 has created the largest cohort of critically ill survivors in history. And this is many of the things that we're learning in the post-COVID-19 condition, critically ill survivors are already robust findings in the ICU outcomes literature. So it's very important to become students of that because it is indeed very instructive. And I'm going to take a couple of slides to just highlight some of the major morbidities of severe critical illness. Angela and I worked together in our 5-year ARDS outcomes study. And we were really able to show that muscle wasting and weakness was a major sequela of critical illness. And this had very durable long-term effects up to 5 years. So this is something that's important for us as we think about the post-COVID-19 condition. And, one of the lasting legacies, in addition to the muscle wasting and weakness and the disability related to that, we know that post-ICU patients, not just post-ARDS patients, have challenges with cognitive dysfunction on the order of mild Alzheimer-type dementia or moderate TBI. These patients also have important and often debilitating mood disorders, anxiety, depressive symptoms, PTSD, The PTSD takes the form of persecutory delusions in the context of delirium. Many of these constructs, the post-sepsis syndrome, the chronic critical illness syndrome, the post-intensive care syndrome coined by Dale Needham, its newest iteration, and the extended PICS put forward by Jean-Charles Prisset and his group in Belgium, that we have many issues that relate to not only muscle, nerve, and brain dysfunction, but the many multimorbidities that patients have when they've spent a long time with us in the ICU. And here are just a few pictures from our Recover cohort study. Problems with pressure injuries, complex vac dressings, et cetera, cosmesis issues as well. This is just to remind us, and this is one challenge in follow-up, that post-ICU patients have a very Byzantine pathway. They have multiple and complex care transitions. And we know this when we follow patients after ICU, but this becomes a very important piece of follow-up and an important health issue when we think about looking after these folks. And I just put some of the 5-year data here to show you that many groups, including our own, have noticed these sequelae over many years. And I suspect this will be the legacy of COVID-19 as well. Just to remind everybody, people don't get sick in isolation. Dr. Cheung and I are also studying family caregivers. This is a patient in the ICU at TGH, and this is when she and her husband gave me permission to show these pictures about 2 years later. It's not an easy pathway back to health, and she was a previously healthy young woman in her 30s. The patient's families develop very severe mood disorders, problems with substance misuse, and it's important to remember that. This is the other piece of this discussion. Not just the patients, but the families have become sick as well, but in a different way, and typically the development of severe mental health problems. And the PTSD data that I showed you from Elie Azoulay's group and from our own Recover group with my colleague Jill Cameron, showing depressive symptoms, moderate to severe depressive symptoms 1 year out, still affecting 27% of patients. Now I'm going to turn to some of the, again with Dr. Cheung's sort of cautionary note. These are very preliminary data. In fact, I got these data today. We have a very complex data set and we're still trying to clean the data. There's a lot of missingness still, but to share some of the issues or some of the findings. So the critically ill cohort is young. These are people with a median age in their early 50s. These are people who still work, who were productive, and most of whom were in the community when they got sick. We have a good age representation across the ICU cohort. We have about a third of people over the age of 60, a predominance of men, which is a a robust finding in all ICU studies. There are more men than women, which is a complex discussion. This group on average did not have a lot of comorbid illness. Those who did tended to have the usual constellation of comorbidities that we've seen published previously: hypertension, diabetes, obesity, asthma, dyslipidemia. This patient group had important pre-existing mental health issues. There's a very important proportion of patients, almost 20%, who are morbidly obese with a BMI of over 40. Most of our patients were partnered, so they were more socially stable patients. You'll notice the median ICU length of stay here was 17, and the hospital length of stay, the median was 22. We had good representation across income tertiles here, and most of our patients were working full-time, and you'll see now in our data set that's dropped quite substantially. The critically ill population, as Dr. Cheung mentioned, has very broad racial representation, which is a bit different from the ambulatory population and to a larger extent than the GIM group. We have people who speak other languages rather than English and French. There's a high proportion of people who use alcohol or have a substance misuse disorder, and a significant proportion of people who have smoked. Now we're still getting our ICU data set organized. It's a very, very extensive ICU data set. So I'm just going to show you a few brief snapshots here. This is just on a small sample of 78 patients. And we're trying to complete that currently. The Apache 2 median was 24. The lung injury severity score, this is obviously at admission, was 3. A lot of patients evolved to have hepatized lungs here at the general, which dominates this ICU data set. The multiple organ dysfunction score at day 1 was 10. And for many patients, it rose from there, but I can't comment on the trajectories at this point. The renal replacement therapy proportion, you can see here in, this is going to be consistent with our proportion in our ARDS cohort, somewhere in the low teens, and that patients who didn't come in on renal replacement therapy had it initiated on day 3. And in the high teens, almost approaching 20% who were tracheostomized. Now at 3-month outcomes, you'll see the numbers are varying across these slides because we still have some missingness. We're still cleaning a lot of the data. But you can see, and based on Dr. Cheung's comment, we still have a high proportion of patients, the survivors, who are reporting at least one COVID symptom. This is consistent with the published literature. The 6-minute walk distance overall was decreased at 64%. The FIM, the functional independence measure, was at 113, but I'll show you at 6 months that this drops. So there's still some instability in these data. Remember that the higher functioning patients are going to be the patients that we see in clinic, and that's where we do the 6-minute walk distance. The FIM will be a better representation because we can do this. It's validated for virtual visits or over the phone, but I'll show you how this is a little bit lower at 6 months. The physical component score of the SF-36 here is 55, so it would fall within the normal range. But again, you will see that there's some movement there at 6 months. So there is some instability in the data set. The mood disorder data are quite significant, and we see this in clinic. Very high proportion of patients with any mood disorder, 34%. Anxiety symptoms, 18%. Any depressive symptoms, 31%. PTSD at 22%. A significant proportion of patients here have had a primary care visit. People have had 2 or more primary care or walk-in clinic visits. High proportion of patients are receiving specialty visits because of complex and largely newly acquired comorbidities. These patients feel enormous stigma. The highest bound of the stigma scale is typically considered to be 44 to 48. These patients are reporting a median of 59. The CD risk, or the resilience score, is also very poor. This is resilience in patients typically who have PTSD. Other comparable groups would be World War I veterans who have diagnosed PTSD, police officers from Hurricane Katrina, et cetera. So these patients are really suffering a lot. You'll see at 6 months, there is some stability in the in-person folks. The 6-minute walk is beginning to creep up. You'll notice the FIM here has dropped. We've been able to capture more people at 6 months than 3 months because mostly they're lost in care transitions. As I mentioned to you, they're in the cohort. We haven't lost them, but they often are not feeling well and they've dropped out of touch with us for a while. Similarly, the PCS of the SF-36 has dropped a bit. I'll point out to you that the bounds of the interquartile range here extend. The lowest quartile is 25. This is extremely low for the PCS of the SF-36. Mood disorders starting to ramp up a little bit here, which is typical in the post-critical illness literature. People are beginning to move away from sort of a focus on their physical health and more in terms of their mental health, and freely reporting now more problems with mood disorders, anxiety symptoms, depressive symptoms, PTSD. Again, the healthcare utilization is significant. Again, the stigma is substantial, and again, the resilience is compromised. Now, we looked at, to share a bit of data, we at the Toronto General, because this was where we started recruiting from, we have a very significant representation of patients from the TGH ICU. So this is interesting in that I can show you some of the data from probably some of the sickest patients in Canada. It limits its generalizability a bit. We're recruiting at a number of other sites, as Dr. Cheung said, and we will have a little bit more balanced data set ultimately when we come to publish this. But just to show you here, the ECMO versus non-ECMO people who have survived, you can see that these patients are very young. The ECMO people are even younger, which makes sense because we were selecting for younger patients when we were triaging this more limited resource. You'll see that the ECLS patients are spending a month or longer in the ICU. So these are intensely resource intensive, patients. And you will see that we had a very important mortality in the ECMO group. So those patients who died in ICU or hospital or death after hospital discharge were here at about 56%. I would say we have a number of patients we're following in the cohort who were decannulated very tragically in basically a persistent vegetative state at other ICUs and really trapped on prolonged mechanical ventilation. So this proportion of ECMO deaths will be 60% or higher in our final data set. I just want to show you that the some of the distributions of ICU length of stay and hospital length of stay here, because the median we mentioned, the median of ICU length of stay is 17 days. The hospital length of stay, 22 days. But you can see that we have a lot of people who have spent an enormous amount of time here in the ICU and in the hospital. So again, this becomes a very crucial healthcare utilization issue, not only acutely because we've got very high resource users who are critically ill, but we've already shown you, Dr. Cheung and I, that we have many patients who continue to be important healthcare users, which is consistent with the post-ICU literature. Just to end here before we get to the discussion, we don't have time to get into a long discussion comparing our cohort with other published cohorts, but to suffice it to say the data are very comparable, which is not unexpected. The Canadian experience, one of the Canadian cohorts that Dr. Cheung and I are leading, will be able to reinforce the importance of some of these themes. The ICU group in our CANCOV study is an extremely sick group, and we will likely be able to contribute some very unique information on what happened to people that we were able to salvage with very advanced life support. So really what we're seeing here in the post-COVID-19 condition survivors, and in particular the ICU survivors, is I hope we've been able to convince you that we're seeing many of the same sequelae of the ARDS patients, many of the same sequelae of survivors of prolonged critical illness, some unique sequelae of the post-COVID-19 condition that are still emerging as we continue to understand what these sequelae, the whole constellation of these sequelae looks like, and begin to drill down a little bit more on the pathophysiology. We have a huge population of traumatized family caregivers, which is a huge issue. In CANCOV, we have many patients reporting, many family caregivers reporting suicidal ideation, not just patients. We have had 2 suicide attempts, one of which was successful. So this is a very serious issue as well. And we really have a system that is, I would say, not fully prepared to meet these longitudinal healthcare needs. And we really hope these data will be helpful to public policy and others as we begin to navigate the consequences of this. So this is how you can reach us. Patients who are interested in being followed can still be followed, and they can self-refer. That's another pathway into the study. And I will just stop there. And thank you again for the opportunity to speak to you today.
Thank you both. Thank you. Thanks for that. And certainly always sad to hear about the suicide and the unfortunate mental illness challenges that are being experienced. I'm going to start off the questioning, and what I was thinking, it's almost somewhat akin to like when HIV first started, that then we started having specialists who focused on the care of patients with HIV and AIDS. You'd almost see that a COVID specialist will become a new subspecialty at some time in the future. And so those individuals are created. What would you suggest to the different centers who are likely to set up some kind of clinics to help follow patients who are COVID survivors? What would you recommend that they think about incorporating into their respective clinics? And is there any sources of guidance on suggestions or recommendations for those types of clinics?
Sure. I just finished talking. Angela, do you want to comment on that? And then I can follow up on that.
Sure. Actually, various places have chatted with us about setting up clinics. And I think it is important to have a generalist to see the patients. And I think it needs to be a multidisciplinary team. Now, it is often difficult to have a multidisciplinary team, but some of these patients require physiotherapy. Some of these patients require mental health assessments and help. So it is really important to sort of know how to connect to those services. And a number of our patients have required sort of neurologists to see as well. So I think establishing something that it's open to people, and because it's new, I like your analogy to HIV. I really would encourage patients to participate in studies. And we will be having a study in early January 2022 called Reclaim. It's an interventional trial for long COVID. So those are some of these, I think in order for all of us to understand this a bit better, it is important to participate in research studies.
Yeah, thanks, Angela. And maybe I'll just add that, many ICU colleagues who are in CANCOV are collaborators, as Dr. Cheung said, are organizing their clinics. And I really think, just thinking broadly, this is a wonderful opportunity to educate all, if you're not doing outcomes work, but just to get involved and educate one's group membership about the continuum of critical care. And knowing outcomes really changes your acute care practice in the ICU. So COVID-19 is an opportunity to initiate that, but many of the outcomes that we've discussed here are robust across a lot of other populations of post-ICU patients and families. We're obviously very focused on COVID-19 currently, but it is a great opportunity to really understand what we're doing in the unit and how to modify our practice by participating in these clinics, without a doubt. I could just add to Angela's comments. Thank you.
Thanks for that. And I won't hog it up. I have a few follow-up questions, but I'll wait. I'll go to Mike, and then I'll add one, and then I'll go to Josée if she's still been able to stay with us. So I'll pass it on to you, Mike.
Well, thanks very much, Dr. Herridge. Dr. Cheung, that was an excellent presentation just to look, and perhaps the most important point, I think, Margaret, that you were just driving home is the fact, the importance for us to, as a critical care community, to be looking at our outcomes. It's really the only way we're going to be able to inform our ongoing practice and improve it, particularly around the issues of of care for the patients and their families. I was struck by the fact that there's such an enormous range of symptoms for this disease. It's quite striking. And you've mentioned the fact that many of the outcomes are the same, or many of the outcomes kind of overlap with the traditional ICU population. Can you comment on what you see as really unique situations for the COVID critical care survivors and their families? Any specific things there that might be emerging from your data?
Sure. Well, I think that these are anecdotal comments, so I don't want to mischaracterize them. Maybe Dr. Cheung wants to weigh in because, there's a big overlap here. Sometimes people were at GIM, they went to the unit, back to GIM, so our worlds are really overlapping here. But a couple of things, Mike, many of the things are the same as you mentioned. The cognitive dysfunction anecdotally appears much worse. And this would be, I think, what one might expect, given the ubiquitous nature of the ACE2 receptors in the brain. I mean, really, there's so many different areas of the brain that are that express these, and this is very much a neurotropic virus. So we definitely see in the post-ICU clinic a lot more cognitive dysfunction. I have seen someone who had almost a Parkinsonian presentation. There are case reports of injuries specifically to the substantia nigra, other areas of the brain that give different, syndromic, sort of neurological syndromic outcomes. So I would say that is different, and that's probably very much a COVID-specific issue. Also, injury to, this happens in critically ill patients too, but the limbic system is very vulnerable as well. So this is another mechanism in the COVID-19 patients whereby they may manifest much more severe mood disorders, because this isn't necessarily related to all the iatrogenesis of the ICU, but actually, again, specific injury to the limbic system. Other issues, I'll turn to Angela in a minute, but I just want to talk about the families, because COVID-19 was very instructive for us as intensivists because the families were completely absent. And the absence of family hurt the family terribly. There was a very wonderful paper led by the Vanderbilt group, lead author Brenda Poon, in Lancet Respiratory, I believe. Anyway, they were able to show that one of the major mitigating factors for delirium, of course, is presence of family. We know that. And delirium was so exacerbated in COVID because, for lots of reasons, brain injury being one of them, but family were not there. And we know that the cognitive dysfunction, or that delirium is a potent determinant of long-term cognitive outcomes. So the family, exacerbated the cognitive problems in the patients, and also they got very, very sick themselves. So, a lot of these things are very instructive to our practice, and maybe, things that were a little bit more COVID-19 specific, just to circle back to your original question. Angela, did you want to comment also on that?
Sure. So I look after the population that's not in the ICU, and I look after the non-hospitalized group. And I can tell you that initially, before last March or 2 years ago, when it all started, we were really sort of thinking that people would recover and would be back to their baseline. And what we're finding is that people are not. A number of them have autonomic dysfunction. They develop something similar to POTS, postural orthostatic tachycardia. They develop exercise intolerance. So I have marathon runners that can't even walk a block, and other sort of Fatigue is a very big part of this. Other than the brain fog, I would say really it's the autonomic dysfunction. The symptoms are very wide. I mean, I have people with similar Parkinsonian type symptoms and tremors, and I have one young gentleman who actually has something called hippus, which is a dilation of the eye, and it's like pulsing. It's like the iris keeps opening, closing, opening, closing. You can just understand how disturbing that can be in terms of to the vision. I think there are specific things to COVID-19, but in the critically ill population, there are also a lot of similarities with other, critically ill population, especially the ARDS population.
Great, thank you. I'll just, Dave, before I get back to you, I'll just make a note. We got a question from the audience about the thoughts on how the visitor policies might have impacted caregiver family mental health outcomes. And so Dr. Herridge was prescient enough to have answered the question even before I got to ask it. So there you go. Back to you, Dave.
Yeah, no, thanks, Mike. Certainly, you'd wonder if we had a do-over how we would do things differently in that regards. I agree. I think it's had long-standing consequences, also on the staff.
For sure.
With it. Yeah. Before I go to Josée, one of the questions that I have for both of you is, do you have any recommendations or suggestions for care providers like Mike and myself and various others when we're counseling those COVID patients and their families, the ones that are progressing slowly, and what would you suggest we tell them about the long-term consequences? Certainly I'm thinking of end of life kind of concerns, but just in general for that. So maybe I'll start with you, Margaret, and then we'll go to Angela, and then we'll go to Josée as well.
Yeah, sure. So I hope that after our ICU data set is complete, that we'll have the ability to provide a little bit more information on how some of our severity of illness measures create trajectories over time, and they won't predict anything, but they may help us to understand who's at an increased risk of death earlier. Because there was so many, you see the lengths of stay are extraordinary. And I personally think some of that is driven by, everyone's uncertainty about what to do, outcome, wanting to be sure that we weren't counseling to withdraw life-sustaining treatment prematurely, et cetera. But I would say, and this is so that's just sort of a general hopefully we'll have information coming forward sort of comment. But I would make some evidence-based comments on published literature. And if you look at the literature on prolonged mechanical ventilation, and I would say some of our own Canadian data from our RECOVER study, we know the following, that with each, and I always tell patients, families this, even before COVID, with each passing week in the unit, we know that that's a risk factor for increased disability. So every week that people spend in the unit, their likelihood of accruing more functional dependency occurs. I personally think we should revisit goals of treatment every week, but anyway, that's a longer discussion. But that's clear. The other thing that's clear is that with each passing week in the unit, the mortality at 1 year also increases. So even if you get out of the unit, you're going to have a lot of disability as you spend longer and longer. That's a truth. That's a published truth. And because you have a lot of disability, a lot of these people that will then go on to die. In our RECOVER cohort, our group of patients who are 65 and older, who spent 2 or more weeks in the unit, 40% of them had died in the 1 year after their ICU discharge. And this is congruent with other published data. And I think these are very important pieces of information to help convey to families and to talk to people more about disability and mood disorders and functional dependency rather than death, because I think death is too binary for people. I think it's much easier to understand what may or may not be acceptable to your loved one when you start talking about dependencies like being able to toilet or bathe on your own, etc. So I'll just stop there. Angela, did you want to make some comments about that?
Yeah, so I've had a lot of goals of care discussion when I'm doing acute COVID ward. And you can see from our data too that the group that's non-ICU but hospitalized are older. And that's because, people have these discussions, the physicians have these discussions with the patient and the families, and some will choose not to have intensive care for the same reasons. And I think it really is very individualized. It depends on patient preferences. It depends on, their baseline function and comorbidities. And when I talk about comorbidities, we're really looking at organ function. How many organs are a problem, even at baseline before COVID? Do they have renal dysfunction? Do they have, already cardiac issues or lung issues? And I think those pre-morbid conditions will predict, I'm talking from a clinical point of view, that they will predict their outcomes. And so I think it's a very individualized discussion.
Thank you. I think we all try to focus on the quality as opposed to the quantity, and it's always so hard to articulate and paint a picture for families. So certainly look forward to getting more information. Josée, I hope you're still on. Do you have a question for Angela and Margaret before we start to move to close?
Thank you. Thank you again, Dr. Herridge and Dr. Cheung, for such a nice presentation. Very instructive and enlightening. And I think it anchors, I think, what we all feel and see. And it helps us, actually, it's going to help us quite a bit with discussions with the families. So thank you for taking on such important work. And I was curious, I know a lot of the good questions have been asked, but listening to all these measures and the impact on both the patients and families, have you personally started either in the ICU or on the ward to have offered or expanded the services right from the get-go to offer these to family and patients, knowing what is starting to come out of this study? So I'm curious about that. That would be my first question. And just a second one, would you have a little pamphlet that we could have in our ICU for patients to self-enroll, either for family members or patient that would like to self-enroll? I think that would be something that we can help with at different centers that may not be enrolled in the study. So thank you again.
Well, like Josée, were you talking mostly about, excuse me, intervening in mental health for offering mental health support?
Yeah.
Is that what you were in particular referencing there, or?
If there is like more social work, if you're starting to think about a more of a multidisciplinary approach for patients right from the get-go, and as well for family members, mental health, social workers, to help them understand, the nature of this disease and to support them. So I'm curious of some of your thoughts moving forward with these results.
Yeah, I mean, I think because, we've continued, both Dr. Cheung and I are full-time clinicians too, so we've sort of been doing this, seeing people in clinic, working, doing this, seeing people in clinic, working. I think you can't help but start to meld all of this together. I mean, there's no question that the the theme saturation starts to hit you fairly early on, and you just start to transmit the information right to social work, physio, spiritual care in ICU, involvement with psychiatry, our mental health professionals, etc. I think that's definitely been a natural evolution for many of us who are doing the follow-up work. And something that we could work on, maybe helping to systematize, and happy to work with the CCSO on that for sure. With, educational pamphlets, there are educational materials that are on the CANCOV website, and the website, is something that you could refer people to for sure, or Dr. Cheung and myself individually. But yeah, I have to say, just doing ICU follow-up work for a living, before CANCOV, I always was on the lookout for families who needed mental health intervention during the unit. And a lot of these who needed, a lot of social support, because you just know where you're headed, and better to get relationships established and resources accessed sooner rather than later, because you can just really foresee the challenges ahead. Angela, did you want to comment on that as well?
Sure. So in the acutely ill patient, it is really difficult to have all sorts of services in because they are infectious. We have concern about how many people actually go into the room. So even though I work in a team, like usually it's me going in and, the other people are charting or doing something else when I'm on anyway. So I think it is difficult in terms of physio or other people, and to do it when they are acutely ill. But certainly once they're not acutely ill, and then we try to get them out, right? And I think the services really, it needs to be in the community, because that's when they're not infectious and they can try to participate in some of the activities. I would say that unlike other diseases, so I'm a pretty taskmaster for my patients. Like when I want them to get well, I'm pretty sort of like, you got to do this, you got to do this. But with COVID-19, one thing I've learned is that you can't push them too much, otherwise they do worse. And they do need a recovery period. And so one of the techniques to try to reduce fatigue is to do resting and pacing themselves. We actually have a video on our website, cancov.net, cancov.net. If Margaret can sort of go back one slide, you will have it there. And under patient resources, we do have some materials for patients.
Thanks, Angela.
That's great. It would be very helpful with that, and certainly we can include that at the CCSO in some fashion. I see Maria has also put up about the survey, and I would ask everyone to take the time to fill that out. It does help us move forward in terms of some of the next steps for OC3PR. I would also be remiss not to welcome Ms. Crystal Pitfield, who's the Administrative Director for Critical Care and Emergency Medicine at Health Science North, who's joining the OC3PR committee, as we're trying to broaden our topics to ensure that we help meet the needs of all individuals out there. I again would like to thank Dr. Cheung and Dr. Herridge. What I've learned is the more you learn, the more you realize you don't know. And
for all of us,
so much, there's so much we could do and we could do better. And you wonder how virtual aspects for the patients, recognizing the infectious risks, if we could address concerns earlier, how we can get some of the much needed specialists like psychologists, which traditionally are not readily available in all of our hospitals, and certainly the coping skills that they can provide for not just patients, but their families would certainly be welcome. And how do you provide care to family members when we're so focused on OHIP numbers and,
Yeah.
about the families? There's so many logistic challenges that the more you talk about it, the more you kind of go, oh, it's potentially overwhelming. So I'll pass it on to Dr. Sullivan for closing comments, because he's always able to bring everything together and bring some sage wisdom to the problem. So thank you both again for this. I wish everyone the happy holidays that are coming, and thank you to Critical Care Services Ontario for putting this together and supporting us as we attempt to help everyone out there. So I'll pass it on to you, Mike, and thank you both again for your presentation.
Thank you for having us.
Thank you.
Thanks, Dave. I was just reflecting on the fact that I think one of the most powerful pieces for me here for today's presentation is the fact that we had Margaret, who's an internationally respected ICU outcome researcher, but Angela was here as well. And I think the critical piece in talking about this is the fact that the patients don't come, on a service-based level. They come as part of a continuum for care,
right.
And it's encouraging to see the push in research that's looking at the entire patient trajectory and their care circle to be able to kind of understand better how we can intervene and help people along the way. So for me, that was a really, really powerful message from today. And so my thanks as well, Margaret and Angela, for your time. I did want to remind people that our next OC3PR will be our first kind of foray out of the COVID world and into something new. That'll be on January 13th, and it'll be about burns. And we'll, again, look forward to you completing the surveys and letting us know what you want to see in terms of topics for the future. So I hope everybody gets a little bit of time off over their holidays coming up, and has a great rest of December. Thanks so much.
Thank you.